Thank you very much, Professor Fatemi. I might retain the remote, and thank you. Can I politely ask a raise of hands who is actually a clinician here? So I assume there'll be very few scientists among you, yes? A few? No scientists? 1, 2 scientists, okay, good. Admin people from IVF centers, no? Okay, thank you so much. It's nice to know who am I talking to. I know Professor Fatemi said that I'm going to throw a lot of light onto this issue, but as we are still in the middle of the pandemic, and if you realize that some units have been closed for a longer period of time, maybe a month or two last year, and then there's a queue of patients coming to see you, progress is made, but very slowly. I have no conflict of interest to declare. The learning objectives for my short talk are fourfold: to understand the effect of COVID-19 infection upon human fertility, to explore optimal interventions to facilitate continuation of services during the pandemic and probably learn for the future, to understand what is published in relation to vaccines and their impact upon human fertility, and to explore the question if we are better prepared to organize our services differently in the future. So I'll start with female fertility first. And I might ask the question, how can a virus enter a human ovary or the oocyte, so tissue or the oocyte itself? So this paper from Singh's group in Germany specifically looked at genetic databases and tried to identify if the human ovary has the entry factors that allows a virus to infect the ovary. And in order for that to happen, and I do have a little drawing later, in order for that to happen, 2 specific factors need to be present. First one is the ACE2 here, and you can see very, very little expression. And secondly are the proteases, the TMPR, don't know why the TMPR SS2 and TMPR SS4. And if you look again at this diagram here, it's a bit complex, but here I'd like you to focus. There's no TMPR identified in the ovarian tissue. So that says that that combination, the unique combination that allows the virus to actually penetrate the ovarian tissue, is not present. So it's safe to say that it appears, at least from databases data, that the ovary cannot be physically infected by the SARS-CoV-2 virus. I'm jumping a little bit, but just to draw your attention to this column, vertical column there, because that's the human testis, and you can see also no serious expression of both ACE2 and TMPR, but I'll come back to that later. What about follicular fluid and oocytes? The evidence is a bit slim, but I think it's reasonable to assume that if you try to measure follicular fluid RNA, viral RNA, you will not find it. And here there's a group from Demirel where a patient underwent IVF. She had a trigger. The next day she tested positive. They proceeded with the egg collection. They had 20 follicles aspirated, 20 oocytes collected. They've analyzed every single follicular aspirate. They could not identify any SARS-CoV-2 RNA in those. The group from Spain, Rita Vacena's group, also looked at 2 patients that were donating oocytes, and they asked a different question. Can they identify viral RNA inside the human oocyte? And they looked at 16 oocytes, and none of them showed positive for SARS-CoV-2 viral RNA. So do we believe that ovarian cells are at risk of SARS-CoV-2 viral integration? We don't. We have the paper from Vacena, and also we have studies from genetic material from monkeys that showed no concomitant ACE and TMPR SS2 expression, thus no possibility for the virus to integrate in the human, at least monkey, oocyte. What about the differentiation between the virus and the disease? And that's quite a fine nuance. So if we're asking the question, is the virus found in the follicular fluid? The answer is pretty clear, no. But if we ask the question, if a patient has the disease, is infected with the virus and now has developed the disease, does this have an impact upon her reproductive ability? And this is a different question. There's some evidence that in terms of folliculogenesis and in terms of the steroidogenesis of the follicle, there is an impact. I will have some very specific pointers on a later slide, but just to suffice to say that this group from Argentina showed that during IVF, women that had COVID, up to 46 days after the COVID, and during the treatment was carried out up to 46 days after the COVID treatment, they showed that there were antibodies present in the follicular fluid, and they had the same numbers of metaphase 2 oocytes, yet the quality of those oocytes was not as good. So the blastocyst formation was affected and the quality was lower. They showed that the previous disease interferes with the granulosa cell activity and it lowers the vascular endothelial growth factor in recovering patients. Oh, that's so fast. Maybe my pressing is a bit hard. My apologies for that. So next one is in relation to the sex hormones and the cycles. I don't know if you see patients that said, I had COVID and my cycles have gone a little bit off for a short period of time. I think there is a link there. This paper from China looked at 177 women in reproductive age. They measured the sex hormones and AMH. They observed no change whatsoever. They did notice changes in terms of the cycle regularity and menstruation, far lighter, but they observed that on average after 2 or 3 months they disappeared. So in conclusion, in relation to the SARS-CoV-2 virus and the disease and impact upon female fertility, the oocyte does not appear to have entry factors that facilitate cell entry for the virus. This suggests that the oocyte might be protected against the infection, but yet the disease itself could potentially affect follicular function and egg quality. And that's the paper from Herrera, which I'll discuss a bit later. What about the man? In terms of male fertility and the impact of SARS infection, there's this paper from Italy where they identified males that had the disease, were diagnosed, then they recovered, and these are 43 patients that they identified after excluding some of them. And when they performed semen analysis on them, they were very surprised to see that 25% had oligo or azoospermia. 11 had semen impairment with 8 azoospermic and 3 oligozoospermic. And of course, you're going to ask the question, but sure, maybe they had azoospermia before the COVID, but the reality is that none of these 8 patients that were azoospermic, all of them had children. One had 3, I think 3 or 4 had 2, and the rest had 1 child. So there's evidence, clear evidence that this is an event related to the disease itself. Okay. Furthermore, the more severe the disease was, and there are people that were ventilated and so on, the more severe the disease, the more severe the impact upon spermatogenesis. These guidelines came up pretty quickly in the middle or autumn of 2020 from the Andrology Society in France, and they recommended that men should wait for 3 months after the disease in order to facilitate recovery of spermatogenesis. So that was the very first recommendation that came out. They also suggested that there are hormonal changes in the testicle with lower testosterone levels, and this in itself could affect reproductive function. And they also made some recommendation in terms of cleaning at that time. So allow space between sperm, 2 men coming in for a sperm test, ensure there's good ventilation in the testing room and so on to reduce the risk of cross or contamination between patients that attend a andrology laboratory. Okay, communication, good. So similar questions are testicular cells or indeed the testicular tissue at risk of SARS-CoV infection? And the answer is no, because there's no concomitant or very moderate expression of ACE2 and TMPRS2. Remember the top right color diagram I showed you where the vertical line really didn't show any co-expression. And of course, there's no SARS-CoV-2 in testicular tissue or semen. And how do we know that? These are, again, a comparison between the viral impact and the disease. So can SARS-CoV-2 be transmitted through semen? These are 3 papers that all showed it cannot be transmitted because they could not find any RNA, viral RNA in the ejaculate. I'm not going into detail because I have them later in more detail. And the disease, does COVID-19 disease, the patient is sick, affect male fertility? We have clear evidence there that it does affect spermatogenesis. There's a significant decrease in semen concentration, total sperm count, and motility. It does return after approximately a month or so, and the more severe the disease, the more severe the impact. So we need to differentiate between patients that were sick in ICU and maybe allow those patients a longer period of recovery, and the ones that had a very mild disease, maybe allow them to start after a month or so. I'll skip this one. So male fertility conclusions, there's no evidence to suggest the virus sheds in the ejaculate. There's no practical need to avoid intercourse as such. If a couple comes in and says, I had COVID, should I not make babies at home? There's no reason not to. And male diagnosed with COVID-19 could avoid HRT for 3 months, and that's just based on that recommendation from the French Society. There is nevertheless, and I'll draw your attention to this paper by Orvieto, there's some suggestion that the male sperm quality might be contributing to poorer quality in IVF, so we'll come to that in a moment. So while there's no effect upon the woman, but there appears to be some effect upon the man, what is happening in the IVF circumstance? Okay. So we have evidence that the SARS-CoV-2 is not present in the follicular fluid. That's the most important thing. It's not present also in the culture medium. After culture, it's not present in the vitrification solution. And the papers are all here for you. And 2 separate papers looked at very specific questions. The first one is the study by Levi Setti, and this is an Italian group that specifically looked at pre-COVID and post-COVID outcome of treatment. And there was no difference in clinical pregnancy rates. You can see here, clinical pregnancy rates per cycle in the first trimester were not different between pre-COVID, which was 25%, and post-COVID, 27%. The group from Canada, Rotschenker, asked a completely different question. If women have IVF, are they more likely to miscarry if the IVF is carried out in the pandemic period? And by the way, all these patients were asymptomatic. So when they looked at the COVID period, these were asymptomatic patients. So the answer is no. The similar viable clinical pregnancy rates in the first trimester between the pre-pandemic and during the pandemic, 80 and 76%. So that means the miscarriage rate before was 20%, miscarriage rate during the pandemic, 24%, not significantly different. So this is reassuring because patients will come in and say, should I have IVF now that we're in the middle of the pandemic, or should I wait till afterwards? And there's no reason to delay treatment based on this evidence. In IVF, truly the most important thing in the end is the embryo. And this is a question that relates to, can the embryo be affected? If the patient has COVID as she comes to you during treatment or after the trigger, can the embryo be affected? So of course it comes down again to, does the embryo have the receptors and the proteases that allow the virus to come in? And the answer is simple. I mean, here we do have the okay, this is TMPRSS2 and the ACE2. And the question is, we'll focus on this, at the top, progressively from the oocyte to the trophectoderm. Yeah, so we have oocyte, we have fertilized oocyte, we have 2, 4, 8 cells, morula, and then the blastocyst with the inner cell mass and so on. And we're looking specifically at 2 areas, TMPRSS2, which is the bottom here, and the ACE2, which is here. And they have to match. In other words, when you put them together, you'd like to see expression at the same time. And you can see that TMPR is not expressed till this level, which is the inner cell mass of the trophectoderm, while the ACE2 is expressed in the early embryo. So basically, there's no synchrony between the two of them. The ACE2 receptor is there up to day 3, then it disappears, and the TMPR protease only starts in the trophectoderm in the late embryo, day 5. So that tells you that in the first 5 days of development, the virus doesn't have the apparatus or the cooperation of the cell to integrate into the embryo. And that is crucially important. But that also raises the issue that it is possible that the embryo could be affected from day 5 onwards. It is possible. So this paper here, I promised to come back to it, the Herrero paper from Argentina, asked an important question. What is happening with women that had COVID disease that undergo IVF? And these are women up to 46 days after the disease itself. And I might draw your attention to the graph at the top left here, where we're looking at number of retrieved oocytes and number of mature oocytes in relation or correlated with the level of antibodies found in the follicular fluid. So if we measure the antibodies in the follicular fluid, and this patient has very high levels of antibodies, the number of oocytes and the number of mature oocytes is decreased. Yes, we can see from first one is low IgG, then in red is medium, and then in green is a high. And you can see there's a constant flow. Furthermore, as I already mentioned, the VEGF is lower in patients that recovered from COVID-19. And even more interesting here, there's a higher DNA damage in the granulosa cells. Now remember, these are cells that support hormonally the formation of the oocyte. So if you have a malfunctioning granulosa cell, the quality of the oocyte will, at least in theory, be affected. So based on this and based on what I just said in relation to the embryo, some groups in China suggested that we should not freeze during a pandemic like this. We should not freeze embryos on day 5, but we should freeze them earlier. So the risk of the virus integrating into the blastocyst, which now has the 2 molecules to allow viral integration, is not present. My conclusions for the human embryos are very simple. That human embryos express entry factors from day 6 onwards only, that pre-implantation embryos are unlikely to be susceptible to SARS-CoV-2 infection, that post-implantation early human embryo could be susceptible to infection, including in the female body, potentially, although we have no evidence. And all this data is based on RNA expression, but not yet validated. Yeah, not yet fully validated. So due to all this fear of, remember in the beginning, nobody knew any of this data. So initially clinics were closed. We restarted after a month with proper triage and testing of patients and staff, remote consultations, reduced number of visits for patients, and reduced number of staff present in the clinics. And the procedures were streamlined and so on. But the outcomes are no different. So a lot of work done, but for extreme caution without any significant evidence of impact. And I have to applaud that vast majority of societies have taken a stand and helped in controlling and supporting patient journey. I mean, this statement from the ASRM, SHIFFS, where the first phrase said reproductive medicine is essential, I think it's a crucial way to support our patients. We have a duty to support our patients. So how did the adaptation look like? Well, it was pretty straightforward. ESHRE suggested a streamlined protocol in which, firstly, we need to care for our staff. So if staff is vaccinated in that situation, they could return to work. In some places that don't have access to vaccination or programs are slow, or some people just don't feel comfortable with the vaccination. In that case, testing will be done every 2 weeks. and then negativity says come to work, positivity says occupational health and isolate, and then there's an interval protocol with questionnaire, triage, and so on and so forth, and ACT. I'm not going to go into every detail. This is published stuff by Eshrei. I'm sure you're all aware of this. Similarly, for patients, again, there could be patient that had COVID, patient that was vaccinated, and if that is yes, follow the standard procedures. May I draw your attention to the top part? So 2 weeks prior to the IVF, be cautious. Then at the start of ovulation induction, and then before the trigger, which is sort of a point of no return. And also, we felt quite strongly that we should ask our patients what happens afterwards. Okay, just because you've had a positive test or a scan, but it'll be nice to know, did you actually get COVID in early pregnancy? What was the outcome of pregnancy? I think that effort will be valuable in the future. And that's why, for example, Eshrei had that invitation for practitioners to submit cases to Eshrei so we can publish it. And if a patient did not have COVID or is not vaccinated, then testing and then test negative, move on, but with triage during the treatment or otherwise postpone the treatment. And the adaptation that I'm sure many of you would have introduced follow the online consultation, online treatment plan, prescription, and even consent these days, stimulation monitoring, fewer visits, and then streamline the triage, maybe with remote apps and so on, and safer access for both staff and patients in terms of PPE and the rest. But there are two aspects that are not often talked about, and sometimes we forget about this one. So one is oncology cryopreservation for both males and females. So here, for example, what should you do if you provided services for cancer patients? Should you take a female for treatment? And of course, if she's negative, it's simple, just follow on the treatment, but she could turn positive during the treatment. Should you stop and send her home? I don't think so, because we have good evidence that the virus is not in the follicular fluid. We have good evidence that it's not integrating into the oocyte, so we really don't have a reason not to treat that patient. There is one reason, and that is she's not clinically well, so you're not going to take a very sick patient that needs admission to the ICU and submit her to stimulation for 10 days just to collect the eggs. Also, maybe just to strengthen this, the importance of providing good care for such patients in the terms of avoiding OHSS. I mean, you should do that in any case for healthy people, but these patients that might have COVID, they're even in a weaker position. So antagonist protocol, trigger with agonist, avoid OHSS, safe practice. And of course, if one has the facilities to provide all this. And these are the three papers that I skimmed a little bit in the beginning, but the answer is the same for male cryopreservation. If it's not in the ejaculate, what's the point in not doing it? Just bring those patients in, proper triage, and just bring them in. So these are the three papers here with good number of samples, and there's no SARS-CoV detected in either sample, either blood or semen, at the time of donor sperm cryopreservation. Once you have a good triage system, then again, patients with acute disease sampled 1 day after diagnosis. I mean, this is high viral load in blood, but no semen sample tested positive for the viral RNA. And then once again, 23 males with disease, no sample tested positive. In fact, there's only one paper that showed one test positive, and that's the Italian paper out of 170 samples. All the others say we cannot find the viral RNA. So also, Paulis says, yes, cryopreserve, you can screen with PCR in asymptomatic males, but there's no presence of virus, so offer them treatment. So prevention is also important. Educating your patients, educating your staff in the circumstances of a pandemic is paramount. We need to train them, we need to encourage sanitation, social distancing, and explain risks. If there are no risks, tell them. We have no evidence of risk. If you want to proceed, let's go with it. And then in terms of staff, similar, educate, protective screens, of course, PPE, shift work, and then creating mini teams. So if somebody gets sick, you have backups all the time. You don't bring all your stuff in, and somebody gets sick, then you have to keep everybody at home. And of course, telemedicine has really taken off, hasn't it? We have talks about this tomorrow, and such an important way to communicate with patients. Donor is the second one. So oncology was the first, but the donor is the second one. And again, we forget about it. And it's nice to be here in Prague because, I mean, Czech Republic is a significant place in terms of donor treatments, okay, and same as Spain. And you can imagine when there was no flights and no access, people could not travel. The services were severely curtailed, and then significant delays in accessing the treatment. And the challenges are, because less patients are receiving treatment, there'll be less patients starting therapy, even investigations. You can't see those patients in the clinics to physically do all the investigations. And I think these are challenges that will continue for the foreseeable future. So the future consequences are beautifully detailed in this paper by Bhattacharya, which I certainly recommend, where he says that the most affected are women that are older. A younger woman will still have good reserve and availability, or possibility to have treatment. And in donor cases, obviously her health matters too. So if you're 49 and you have a COVID issue, then or pandemic, you'll be 42, 43. People will not treat you. So we must give priority to advanced age women. 2 slides on vaccination, and I'll be quick, Chair, sorry for the delay. So is response affected in IVF if one had vaccination? So vaccinated patients undergoing IVF. So there are 3 groups here: vaccinated first, recovered second, and then controls. And you can see the p-values here are no different. We're talking age of the patient, antral follicle count, indication, and then how many days after the disease. And of course, the recovered patients had longer because they just took longer to start treatment. And when you look at the levels of immunoglobulins, antibodies in serum or follicular fluid, there was some difference here in vaccinated and unvaccinated, sorry, that's a serum, and in follicular fluid, no difference whatsoever. And when you actually ask the question, is IVF treatment, are the outcomes different? An interesting thing, we talked about progesterone. If you look here, vaccinated recover from COVID and controls, and you can see that the controls had a lower trigger day progesterone compared to the vaccinated and the recovered. It's just an interesting observation, but nothing else was different. Neither the type of trigger, nor the serum estradiol on the day of trigger, nor the serum progesterone on the day of egg collection, and so on and so forth. Mature oocytes, there was no difference whatsoever if you had the vaccine or didn't. So the answer is the vaccine does not affect the response in IVF. Are the laboratory results affected? They're not. Everything is non-statistically significant. And does vaccination affect sperm quality? This is what our patients are asking. Hey, doctor, should I have vaccination? I don't want my sperm to be... Now, reality in this paper, if you carefully look at it, is quite interesting, because if you look at what the authors showed, this is before and baseline, before and the follow-up, and there are 45 participants. They had the first sample after 2.2 days of abstinence, the second sample after 2.8 days of abstinence, and I'm not going to comment about the significant difference, but the men that had the vaccine had the sperm improve afterwards. Now, I don't think the vaccines have that magical capacity to improve sperm quality, but the message here is that it doesn't affect it negatively. So can you have the vaccination? Yes, you can. It will not affect your sperm quality. And are we better prepared? I think we are. I think we learned to pause, to protect our patients and support them. I think we learned to establish quickly if it has a reproductive outcome or not. I think also that we need to take responsibility and not severely restrict therapy, because fertility is a time-dependent treatment, and we have to involve all actors in a code of service, as I showed you. 3 quick slides. I'm not aware that, sorry, I don't know if anybody of you have seen this, but the IFFS did a questionnaire with all our member societies in the middle of the pandemic in early 2020, autumn 2020. And in blue are countries where the services were closed. Okay, it's the vast majority of the globe, if you can appreciate. And then we asked the question, we asked the question, what was the reason for closure? And you can see government, voluntary closure, people felt afraid, and then professional societies like ESHO, SIRM, and so on. And the most important slide is this one, because we asked this question: does your country consider fertility treatment as an essential medical service? And you're not surprised, I'm sure, to see that 75% of countries said no. So while we continue doing other medical services like delivering babies and so on, we consider fertility different. And this is something that we need to take stand, I think, in the future. So the lessons learned, this is my last slide, the lessons learned are to seek clarity on impact upon reproductive services, early scientific assessment, create groups that look at the data, support patients remotely and continue therapies if risk is small, global coordination, big organizations coming forward, prioritize the most affected by any delays, and keep a vigilant eye. We're not out of the pandemic, but keep a vigilant eye on the long-term impact. We will see probably the waves later. So with this, I'd like to invite you to attend the World Congress the IFFS is organizing beginning of April. Thank you so much, and sorry for a bit of delay.
Thank you. Some light into this box of COVID. Now, due to lack of time, I have many questions here, but I would like you, some of them you have already addressed. If you answer very short answers, please. So the first question, what's the evidence about COVID vaccine and implantation? And I think you have addressed that. So the next question is, I heard the virus is not found in the follicular fluid, but the disease may impact fertility. I did not capture what specific impact it may have. Can you please elaborate?
Yes, it does affect the quality of steroidogenesis in the ovarian follicle, resulting in lower quality oocytes and lower quality embryos after IVF.
Okay. Now, the next question is, how is it possible that the sperm parameters return to normal after 32 days when the process of spermatogenesis usually takes twice as long?
That was an average. And these patients were not immediately tested. So up to 46 days following the disease. So they already had a lead start of up to 40 days plus another 32 days from the moment of having the measurement done. So that brings you over 70 days.
Okay.
But the more severe the disease, the more severe the impact and the longer the recovery.
Specifically now with Omicron going around rapidly, the next question I think is a very valid question. What do you do if the patient is currently diagnosed positive during a stimulation? Do you go ahead with an egg retrieval or do you cancel?
I think it depends on the facilities that you have. So if you have the ability to treat this patient, providing you can discuss the quality and the potential impact of the viral presence in her body and the patient desires to have treatment, I think it's reasonable to proceed. The alternative will be that you don't go to day 5 and you just freeze the embryos on day 3 where there's no viral integration into the embryo, and then you use those at a later stage.
Thank you. For the sake of time, I'm going to ask you one last question, and there are more questions, so during the break, if you have more questions, you can always address them to Professor Mukwano by himself directly. Should we delay the treatment? If so, for how long after the vaccination?
As shown, there's no evidence that vaccination impacts the quality of the oocytes, the percentage of mature oocytes, and so on. I think in relation to current practice on the ground, it might be wise to wait for a month, but I doubt that anybody can start a patient just like that overnight when they want to start the program. But I think maybe 4 weeks is good.
Okay, thank you very much, Professor Mukwano.
Thank you.